Jeannie has beautifully prepared the next section, and there will be a little bit of overlap, I think almost unavoidably. Which one is it? Oh, let's try again. Oh, I did. Yeah. Okay. Oh, come on. Always too. Do it on the keyboard? Okay. Yeah. All right. Very brief outline. Nothing special to it. The set and setting. Set you have already heard a lot about. I have taken the liberty, since we had two speakers talking about transplantation, to cast the net relatively wide and include also some material that is based on studies not only in patients with myelofibrosis or myeloproliferative neoplasms, but with other myeloid malignancies. And so what are generally, I mean, you just extensively discussed by Jeannie, when do we do transplant? When is it appropriate? Our sort of major indications, just to put them up there, marrow failure, disease, quote, acceleration, however we define it, leukemic transformation as a more advanced step of that. And then, of course, failure of non-transplant modalities, although, as also emphasized in the previous talk, that is usually a decision where the impact of transplantation is less than if we carried it out earlier. You have heard a lot about classifications, and I won't spend a lot of time on that. DIPS, DIPS plus, MIPS plus, 70 plus, version 2. I think Dr. Rostov, that he counted about 11 or 12 by now, and I'm sure that is no exaggeration. And based on what we heard earlier today from Dr. Nangalia, talking about individualized decision-making, we will probably have a long list of classifications, and they continue to evolve. And I don't think it can be overemphasized. Once you sit down with an individual patient, you can forget all of those. It's one patient that counts. And then I think the parameters that go into the decision may deviate quite considerably from what the published classification system tell us. This is taken from a recent paper talking about splenomegaly. Should the patient with a large spleen, primary myelofibrosis, have a splenectomy? This was a long debate, and I will say, even though I'm a co-author on that paper, I don't agree with everything that is in it. I think spleen size is a factor. We generally consider splenectomy only if patients have, for example, a splenic infarct, painful, etc., or have humongous spleens that fill out the entire abdomen. Then transplant can be impacted, delayed engraftment, and so forth. But this is not. There's morbidity, there's even mortality associated with it, and so this is not something we do routinely. And we see very few of those, certainly since the non-transplant options have improved and have become widely available. We heard a lot about that already, and we'll hear more. Here is an example of a patient who presented with primary myelofibrosis. Chest X-ray was abnormal. We thought initially he had a fungal infection. He had a biopsy, which turned out that he had a big chunk of bone marrow basically sitting in his chest. So again, a very advanced stage, not what we are looking for. We would like to do the transplants earlier because the chances for the patient are much better. You heard already a lot about the set. So I have taken quite a bit of information based on abstracts from the recent American Society of Hematology meeting that took place mid-December, early December. And this is one example where the investigators collected information on almost 200,000 individuals, not patients, in the UK Biobank. And again, Dr. Nangalia can tell you more about that. And among those almost 200,000, they found 11,000 individuals who met the, quote, CHIP, clonal hematopoiesis of indeterminate prognosis, and CCAS, clonal cytogenetic abnormality of unknown significance, and then looked at how those patients were doing. In other words, this is relevant also to the question I think Dr. Silver asked a little earlier today. And interestingly enough, and I think quite relevant, here what is shown on this slide is the following. In these patients with CHIP-seekers, what is the impact on the type of mutations that are present? And what is shown in pink, red there, is basically the impact of what is considered, or what are considered, high-risk mutations, the probability of progressing over a decade there to a clinically relevant myeloid malignancy is very high, whereas with other mutations, this risk, yellow and green, is very low or even non-existent. So the type of mutation, certainly the number of mutations, all that makes a difference. Now, this is an interesting study, again, presented at ASH, this and the next slide, which I think I will spend an extra minute on it as follows. What these investigators did, they looked at the patient goals and the actual treatment intensity that was offered to them, divided into male and female, women and men, and 3 different age groups. As you can see here, I focus on the leftmost, age up to 69 years of age, and shown in orange for men and yellow for women is the preference of these patients for quality of life rather than length of survival, which is shown in blue and gray respectively, the same for the other age groups. And as shown on the next slide, this is the intensity of the regimens actually given to those patients. In blue, high intensity transplantation, and within transplantation, again, high intensity regimens, and in orange, low intensity. So this is quite discrepant actually from the patient's original goal, influenced by discussions with physicians or attempts by physicians to convince patients of what the best treatment would be and so forth. I think this type of analysis, we need more of those, and I think we need to take that into consideration when advising patients. This is not the same type of questions, but another relevant question in regards to the quality of life or what patients would like to get out of their treatment. The CTRA, I confess to you, I was not very familiar with that myself until I came across those data. As written, there is a composite risk score focusing primarily on pro-inflammatory cytokines. We have heard a lot about inflammation, TNF-alpha, interleukin-1, etc., TGF-beta, and the expression of genes that have antiviral activity. And without going into further details, it's quite a complicated or complex analysis. There was a very high correlation between a low index for or score for CTRA and a high quality of life objective of those patients. Talking about timing of transplantation, to come back to that once more, Dr. Palmer talked about it. This is from a relatively recent paper by our colleagues in Canada, trying to, again, in a somewhat involved analysis, at the question, what is the best timing? The horizontal axis is month to transplantation, and the vertical axis, sort of the likelihood of gaining by transplantation. And as you can see, if you look at the larger dashed line, the lowest curve, DIPS high patients really don't stand to gain very much if they wait a long time. The peak is at about 1 year, whereas in the solid black line, the low DIPS score, these patients are likely to gain even 5 years or even longer down the road. So I think this is, again, it's a theoretical paper, but it is very helpful when you look at patients and try to make recommendations. So when we get to transplantation, the field has also evolved and changed dramatically. This is a set of data taken from the CIBMTR, covering basically 2 decades from 2000 until 2020. And what is shown there in different colors is the proportion of patients who were transplanted either from matched related donors, which is the dark blue at the bottom, and you can see that has decreased from 51% down to 22%. In orange would be matched unrelated donors, which has increased from about 18% to almost 50%, 43 here we are. At our center, in fact, the majority of patients get transplants from unrelated donors. And that is true at most centers, hence this shift here. And then, of course, in green, you have the increase in patients being transplanted from HLA haploidentical donors, so usually parent or child, occasionally a sibling, who is matched for 50%, one of the chromosomes, but not for the other one. And there has been a lot of progress in that field as well. So what about the outcome? These data are a few years old now. I apologize for that. Update was not quite ready. Using the DIPS plus classification about which you have heard, these are patients transplanted from matched related or unrelated donors using various regimens. Shown in black is the outcome, the probability of progression, relapse-free survival in patients with low or intermediate 1 risk disease. There were very few low risk for reasons we just discussed. In blue, intermediate 2, and in red, the high risk disease. So just confirming what we have been saying and what you heard already from Dr. Palmer, as the disease progresses, the probability of successful transplant declines. Here is a breakdown by age. Even though that difference has shrunk considerably, even as the median age at the time of transplantation has increased, this 54 was just a 50%, the median, and you can see there is a somewhat better survival in patients who were younger than the median, 54 years of age or younger, in comparison to the blue line patients who were older than that. We have transplanted quite a few patients now, certainly in their 60s and even early 70s, with results which are quite similar. Not necessarily advisable to everybody, but these are the data. Now, just very briefly, it's a somewhat complicated figure, but we have talked about secondary post-ET or post-PV fibrosis in comparison to primary myelofibrosis, only to illustrate the point that the pattern, the impact of mutations in those 3 different subcategories is not necessarily the same. And what these authors pointed out is that patients with post-ET myelofibrosis, the left lower graph, have a higher risk, for example, of non-relapse mortality than patients who, dependent upon the allele frequency, a difference that was not seen with primary or post-PV fibrosis. And we also know that, we have said that already, that the impact of certain mutations such as ASXL1 is not the same in, let's say, post-ET fibrosis as it is in primary myelofibrosis. Too sure bad, no matter how we look at it, are TP53 mutations. This is combined data from our center and from the German group in Hamburg that were also presented at ASH. Sorry, I didn't put the author down there. That's Dr. Gagelmann. With patients who had a TP53 mutation and were transplanted, 35% had relapsed at 6 years compared to only 2% who had wild type TP53, non-mutated. But just to be a little bit more explicit here, it is also clear by now, I took the slide out because it was very complex and involved. It is also clear that it depends upon whether you have a single TP53 mutation or a double hit, whether you have it monoallelic on one haplotype only or on the other, and what type the TP53 mutation is. So it's a little bit more involved. And again, that only feeds into what we have been hearing all day long, that one has to really try to be more, make individual decisions. And here is the impact of these TP53 mutations shown Graphically, the purple line up there is patients with wild type, non-mutated TP53, and at the very bottom is patients with biallelic, so at least 2 mutations. A big difference. The problem is, what are we going to do about it? Because we still don't have a good modality that would tackle the TP53. There has been one agent, APR-246, that has shown some promise but didn't quite meet the end point in the study, so I'm not certain yet what the availability of that or similar agents will be in the foreseeable future. Now, a little bit more into the area of where donor selection plays a role. This is a comparison, and there is a full-length paper by now looking at older siblings versus younger unrelated donors, matched in both instances, matched for HLA, the major histocompatibility antigens. And even though these curves don't look strikingly different, the solid versus the dotted line, there was a clear, statistically significant advantage in regards to non-relapse mortality, as indicated in the right upper corner, with younger unrelated donors. So the emphasis has to be really on young rather than unrelated. Usually related donors are of a similar age as the patient is, or at least not very far off, whereas with unrelated donors we can select a 20-year-old donor for a 70-year-old patient. And as shown on this slide, that difference in age apparently also, it's very small print, I apologize, but the 2 red boxes there indicate whether we adjust or look at all patients, that younger donor age, being unrelated, was associated with a greater, a more potent graft versus disease, graft versus myelofibrosis effect. And so indeed, I think the policy across the board now is that if and when we look for a donor, not only for this disease, but for other diseases as well, we look for a younger individual, generally same sex, HLA matched, and then we look at a few other things. ABO blood group has a minor impact, and exposure to various viral pathogens in the past. This is recent data unpublished that my colleague Rachel Salit is putting together, Shona data on 61 patients with primary and secondary myelofibrosis. She has actually 95 patients on that study by now. And what is different from our previous slide that I showed you, these patients all received at least 2 months worth of ruxolitinib prior to the actual transplant conditioning, and the ruxolitinib was tapered off during the transplant conditioning. And these are overall, or all comers, showing overall survival in the range of 70% out to 4 to 5 years, which appears to be different. It's not concurrent data from what we had shown before in the publication of 2017, where I showed you separated low-risk, intermediate, and high-risk patients. So these are all-risk patients, including high-risk patients. Non-relapse mortality was about 20% overall, and relapse was relatively low. It was somewhat, I think it was 9% so far. Right. Now, GVHD, as we were just saying, is still an issue, and from the same study by Rachel, our data here looking at chronic GVHD, which can of course be a very significant and sometimes devastating complication in patients. Any chronic GVHD, overall about 40% now in some cases. This is mild, dry mouth, for example, dry skin. Moderate to severe in about 20 to 25%, still too high. And this is, and I will show a slide or two on that, where the use of post-transplant cyclophosphamide, in other words, basically giving additional chemotherapy on days 3 and 4 after the donor cell infusion, has a benefit. It doesn't prevent chronic GVHD completely, but it has clearly an impact. That field is sort of exploding with removal of naive T cells is another approach that is being applied there. And then, since I have been in the field for a long time, I allowed myself to include this slide as well. When I started, we used a lot of rapid ATG, in other words, antibodies against human T cells that were generated in rabbits, which again, very popular in the form of thymoglobulin. And what these investigators put together there is making the point that inclusion of ATG, anti-thymocyglobulin, in the conditioning regimen here, given at a low dose, day -2, was beneficial in comparison to patients who did not receive ATG when it comes to overall survival in the range of 70 to 75% compared to about 50%. So it is still a very useful, valuable agent, and these are the patient characteristics. I won't go through detail. It did include myeloproliferative disorders, but as you can see, also AML and MDS patients. And then from the very old days, or old tools, to very new tools, these are preliminary data on itacitinib, another inhibitory molecule that some of you probably are familiar with. This is a study done at City of Hope. Preliminary data suggesting that the incorporation of itacitinib, which is shown here in the red dotted line, in the peri-transplant period, is useful in reducing GVHD, although the survival curve in GRF stands for GVHD and relapse-free survival is still somewhat disappointing. I think more data need to be generated before that, if at all, that can become a more standard compound to be included in our transplant regimens. Now, another interesting molecule is SRG12001, which is, as indicated here, a liposomes of fat in globule, basically, that you generate that binds CD1 receptor and leading to activation of invariant NTK, and natural killer T killer cells, which play a role in GVHD development. So this is quite encouraging, this curve here at 70% or slightly higher, because GVHD, in addition to relapse, is still the big complication after transplantation. Another attempt at reducing that problem, I'm not quite sure why it was called ORCA T cells. What it basically is the following: a separation procedure of the donor cells that enriches for regulatory T cells while removing classical cytotoxic T cells. And this data, again, this is a single-arm study, but a randomized study is planned or already underway, I'm not certain. This was presented by investigators from Stanford University, showing certainly for patients with MDS and acute leukemia here, who did not have a residual disease at the time of transplantation, that's what MRD stands for, measurable residual disease, are quite encouraging, even though the follow-up is only 1 year. So again, it was an abstract at ASH, but these are some of the studies that are currently ongoing. I referred to this one already, the use of Cytoxan to be given after transplantation, originally pioneered by the group really at Johns Hopkins, showing in a randomized study, this was a late breaking abstract, so it stirred a lot of interest, comparing the results with a more standard regimen, tacrolimus and methotrexate, as given for GVHD prophylaxis in comparison to post-transplant cyclophosphamide given on days 3 and 4, showing a definite, statistically significant advantage for the addition of Cytoxan. One disadvantage, if you wish, is that we, at least at our center, we have to admit patients to the hospital for the Cytoxan, whereas many of the other transplants are being done in the outpatient setting. But even that is again under revision now. The dose of cyclophosphamide is being reduced. There's a study initiated by the NIH from 50 milligrams twice a day on 2 days down to 25 milligrams. And we will have to see what the optimization shows. These are the characteristics. Again, it's not worth really going through them in detail. And this, just because of the detail provided in the study, I thought was of interest, even though here the focus was on MDS. There were some overlap syndrome patients in it by the group in Boston using venetoclax, the BCL2 inhibitor, in combination with azacitidine, the hypomethylating agent, which has been around now for, 18 years, I think. So whereas venetoclax has been added more recently. Small study, conditioning regimen, venetoclax, 3 drugs, as you can see here, and then a matched transplant, HLA matched, given the somewhat more standard prophylaxis for GVHD, and then maintained, and that is the important part of it, post-transplant with additional chemotherapy. And what they reported was really what impact did this regimen have on the mutations that characterized the disease at the time of transplantation. That looks a little confusing. Just left is before transplant, right is after transplantation, and then color-coded is who received maintenance in yellow. There were a few patients who did. So each vertical line is a patient, each horizontal line is a mutation. And as you can see, there are fewer mutations detectable after transplantation, but by no means is that a tabula rasa. There are still mutations. You can see DNMT3, there is TP53, which is still present. Anyway, there is a reduction in the presence of mutations, and I think that sort of is worth pursuing further, but how? Maybe we can intensify the post-transplant regimen. Maybe we can further modify the conditioning regimen pre-transplant in order to clean up more efficiently these mutations, and by doing so, hopefully, reduce the likelihood of relapse post-transplant. So, in summary, briefly, what did I tell you? There has been a lot of progress. It's clear that JAK inhibitors are beneficial pre- and post-transplant. I didn't show a lot of post-transplant data. We have a study ongoing right now, as have a number of other centers. We will see what it does, particularly in regards to GVHD prevention, since the JAK inhibitor, certainly ruxolitinib, has been approved for the treatment of GVHD. That prevention is improving by a number of means: naive T-cell removal, cyclophosphamide given post-transplant, selection of regulatory T-cells, and so forth. I emphasize that TP53 mutations still are bad, although it depends upon what type of mutation you have, what type of mutation you have. I think we need, and we have been, that's why we are here really, more power in our interactions with patients in the decision-making process, and really I think it behooves all of us not to try, as Jeannie said in the previous talk, try to push a patient into a transplant when it is really not in the patient's best interest. We have not talked a lot, I have mentioned it, the inflammasome, the inflammatory environment, which has been described in a lot of different settings by many different investigators, and there are data coming along as to how to block certain inflammatory pathways, because this inflammation clearly, and I think Sergin has worked on that as well, play a role in the propagation of the disease, maybe even in the initiation of the disease. And I think if we can come up with better means of interfering there, we will have better results. Thank you very much.